What should patient-centered research and treatment look like? With Drs. Giselle Carnaby and Michael Crary. Coming up next. Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia care. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for conversations aiming to bridge the gap in dysphagia education and practice. We value diversity in backgrounds and opinions, so our guests will not always reflect what we believe. Through critical reasoning and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. I have two guests with me today, Dr. Michael Crary, who is retired from a 44-year career as a clinical researcher in many different places, and Dr. Giselle Carnaby, a professor of public health and speech pathology, among other things, currently at the University of Texas Health Science Center in San Antonio. So that's a little bit of information about you, but what's maybe something either that you want people to know or maybe that they don't know about you?
I guess I'll start. Most people don't know that I started my career focusing on children and adults with apraxia of speech. And I spent about first 15 years of my career doing that, overlapping as I get into dysphagia. And in 1993, wrote a book on that topic, which stayed in press for 25 years without revision. And it's no longer in press, but it's there. I've also worked in the area of aphasia, working with such notable people as Andy Curtis, the guy who developed the Western Aphasia Battery. And I really got into aphasia in the early 1980s, 1981, 82. Like a lot of people of my generation, by mistake, I was asked to see a patient with a swallowing problem who'd suffered a stroke, and just kind of had to figure it out from there. When I went to the University of Florida Health Science Center in 1984, I actually started the dysphagia program there. And I'm not sure people would understand that I had doors slammed in my face. I was called a crackpot. You can't help this problem, etc. But 40 some years later, here we are. And I think we've proven them all wrong. That's about the end of it.
That's fascinating. And just as a point of reference, you and Dr. Grower were the authors of my textbook when I was a dysphagia student in graduate school.
Yeah, that textbook went through 3 editions over a period of just over 15 years. Mike and I decided not to do a 4th edition. We felt that we had both retired, and textbooks ought to be written by people who are active in the field, both clinically and empirically. And that certainly wasn't us anymore. So we're turning it over to people much younger and smarter than we are.
Fair enough. Fair enough. Giselle, how are you doing today?
Good. How you going?
Going okay.
Same question, I'm guessing.
Same question, unless there's anything else you just want to talk about. I don't know.
I mean, it's pretty obvious I'm Australian, and I did all my training in Australia, including my PhD. So I did not train in America. I came to America many years ago as an assistant professor, as a visiting assistant professor. And my background in Australia was such that I actually focused in public health. So my higher degrees are in public health. Both my master's and my PhD are in public health. And I spent a lot of time in Australia working as a research fellow for neurology. So I worked on clinical trials for neurologists as their clinical coordinator and their trial gruntist, basically. The person who pulls the blood, spins the blood, runs around, checks on patients, includes them, recruits them, does that sort of stuff. So I grew up with research in the blood, if that makes sense. And so even though my base degree is speech pathology and I'm still a clinician, I still see patients and I still do clinical speech pathology, my research background sort of overshadowed everything. It was really neurology and then later on in oncology.
Yeah, and that's actually something I wasn't aware of until, 10 minutes ago when we were talking earlier. But I mean, I'm all for cross-pollination. I think it makes a lot of sense to get people who know a lot of different things about a lot of different things and bring them together. Makes a
It was
tremendous
kind of
amount
job
sense to me.
security for me.
Job security?
Yeah, absolutely. Absolutely. It has certainly been the case that I have been employed in multiple different places in multiple different roles. So in population health, in public health, and now in health sciences. I'm not really employed as a speech language pathologist educator.
So wait, if you're not a speech pathologist practicing educator right now I can't say that because you are an SLP, but I'm just trying to take a jab at you and at Mike, because if he's retired and if you're not practicing as a professor of speech pathology, I don't know, I probably didn't even say that right, then why on earth are you here? Because I feel like there's a reason that you're here. I think you both have contributed a lot to something, well, let me say it. Let me step back a second. You both have contributed a lot to many, many different things. But today it sounds like you'd like to talk about patient-centric research. Is that right?
Yep.
What on earth is that? What is patient-centric research?
You want me to take that one?
Oh.
Well, we look at it as clinical research that's focused on real-world patient issues, needs, and values. So we're talking about targeting specific patient population, asking a real-world question. What are things that if we could change will benefit this particular patient population? What are things that they need? So it's not necessarily an esoteric approach to research or mitten research. Mitten research we define as, oh, I have this intervention, whatever it may be. I'm going to try it on this group. I'm going to try it on this group, and I'm going to try it on this group just to see what it does. In patient-centric research, you're asking real-world questions that if you are successful, you provide a very functional answer that will benefit that particular group of patients.
So not just doing your research on patients, but also for the benefit of patients. It kind of orbits the patient, so to speak.
Well said. Well said.
And in many cases, the patient's directing the research.
Okay. What do you mean by that?
So it's the patient's response to what you are doing with the patient in a setting of intervention that drives the next step in the intervention.
Okay. So kind of like a multi-tiered thing that may, if you're researching one thing and you're getting X results, that's going to influence the next step, your next hypothesis, that type of thing, the next investigation.
And your next step in any protocol that you're following. So, people follow a protocol, but sometimes they follow it like a cookbook.
Oh, right.
And it's not patient-centered at all. It's protocol-driven, but not patient-centered. There's a difference. So in a patient-centered approach, you're evaluating in the moment how that patient is responding to each movement or direction you make in any protocol or any approach.
So a word that's been really hot lately is standardization. Is this at odds with standardization?
I don't think it's at odds at all. I think that standardization is what you as the therapist is going to do, all right, so that you're not just freewheeling. But I believe that patient-centricness, if that's a word, centricness, is being responsive to the patient's performance. And if you're not responsive to the patient's performance, then you're not where the patient is at. So you can still be standardized and have options available to you that is within the breadth of the protocol you're applying, but you're responding to the patient's performance level. And you're increasing or decreasing prompts, supports, or steps associated with what that patient does. That still fall within a standardized protocol.
Fair enough. I appreciate that. So I would ask you why this is important. I think you've answered a lot of that already, unless there's anything else that you want to put out, why patient-centric research is important. Kind of intuitive seeming, but...
It is, but, maybe it's too simple a concept. So an example on the other side of what would not be patient-centric research. Many of us, Giselle and I included over the years, have done research on healthy adults, sometimes graduate students, sometimes community dwelling elderly, et cetera, et cetera. And that research is valuable. It helps us identify what I would call proof of concept for any particular intervention or stimulus, whatever you want to use as your measure or your target. But it's not appropriate to take those results from healthy adults who don't have clinical issues and then say we're going to apply those directly to patient populations. So what we have with healthy research is examples of physiologic change, proof of concept that our intervention can make a difference or our stimulus can make a difference in the swallowing system. But yet with the next step will be going to a more patient-centric approach. Now that I have that proof of concept and I have some idea of what kind of change I can see, will I see that in patient populations? And do I have to modify my intervention to fit a particular patient population? So that may help clarify it for the listener a little bit in terms of, what we consider patient-centric focus versus proof of concept or other types of research.
Yeah, I know quite a bit of research in dysphagia is done on done on individuals with healthy swallows, even on graduate students and whatnot. What are, do you think, some of the biggest barriers in getting the patient-centric research that we need?
I think I'm on. I just got pointed at. Okay. I think some of the barriers, to be honest with you, is knowing how to put study design together, knowing how to recruit in individuals with particular diseases or disorders that we are interested in. When you go through grad school, you get taught all sorts of things about the basics of research design. You get very little practical experience in research. And you're lucky if you ended up doing an honors thesis as part of your master's degree, you might get a little bit, or if you happen to work in a lab with a researcher where you're exposed to it. But the nuts and bolts of how, if I'm a clinician and I'm working in a clinic and I want to institute some way of standardly measuring things in a patient population I have exposure to, how can I roll that into some simple research that's patient-centric research? That sort of application is not taught in grad school. So a lot of people are self-teaching along the way. And one of the biggest problems we have is getting large enough numbers of people in studies that have real dysphagic issues so that we can apply a patient-centric approach to evaluating what they're doing and how we can improve their swallowing and swallowing disorders.
Let me give, I think it's appropriate, and if not, either of you can cut me off. But I want to give a real life example from our own history.
You should see the look on Giselle's face as he gives that caveat. I'm going to say something, and it may or may not be appropriate. That was utter terror. I know it wasn't, but I can see the look on your face.
This will be appropriate. When she was talking, it reminded me of the development of the functional oral intake scale. And most people don't know the background of this. This was actually started, 2 or 3 years before Giselle came to join our team. Michael Grower and I were struggling with coming up with a way to document what people were actually eating and drinking on a safe and functional basis on a daily regimen. And, we knew a little bit about research. Our generation, Mike and I, were not trained to be strong researchers. We were trained to be teachers and clinicians. And all of our careers, both of us were both of those things and dabbled in research along the way. So the first POISE scale, if I can use that term as functional oral intake, POISE, actually had 10 items on it. We had a large data set from a couple of surveys and a lot of patient data, and it had 10 items, and we just didn't know what to do with it. Well, Dr. Carnaby came across the pond and joined our team, and we presented the problem to her, who has a very strong research background. And within a short period of time, the tool was validated and cut down to 7 items. And then later on, we actually did a second validation because initially it was in neurologic patients. We did a second validation in head and neck cancer patients that showed the scale was fine. We didn't have to change it. And unfortunately, we never actually published those data, but we have the data or had the data. And so we knew that it was valid in both those populations. And I guess the point is there that, Mike and I had the patient-centric focus. Giselle had the research focus. And those two things working together are actually what led to the development and dissemination of that scale.
I mean, you can think about a lot of barriers and why it would make sense that it took kind of this team dynamic to really get as deep as you did. Just within our training, I mean, we've got so much to learn about. And so to come out and to become proficient, however you label that, for working with patients with swallowing disorders, it's pretty hard. There's a lot of work that goes into it. You get better and better as you continue to develop throughout your career. I can imagine it's fairly similar, like if you get a research degree, if you get a PhD or something that focuses you more on research. And so to be able to put those two skill sets together in a way that you're really digging deep and getting some great answers, I can't imagine how much talent that has to take. And with thinking about studies that aren't necessarily patient-centric too, I mean, taking people who don't have issues, just thinking of this off the top of my head, I don't have a particular study or a particular person in mind, but like lingual pressures or something like that. Like if you wanted to measure, does the effortful swallow increase lingual pressures after, generalized after a number of weeks or a number of months or whatever? If you take normal swallowers and do that, and then maybe have them use the IOP to measure the pressures a week post, a month post, whatever, it's easier to design that study. It's easier to get participants. There are less confounding variables versus if you're trying to get patients and you have a patient who has had a stroke and maybe they don't have any lingual involvement at all. So that's not an issue. So they might say like, yeah, I want to be a part of this study, but then they come and they don't meet your inclusion criteria. And I don't know, I can just think of a million different ways that using real patients in some of these studies would complicate things. It would make it a lot more difficult. What has allowed you to be successful in doing that? And what do you think is perhaps one of your best stories of success with that?
Me again, I guess. Okay. You're right. People are complicated and they're messy. I'll be honest with you, especially patients. Patients are messy. And good planning upfront, knowledge of research and research design certainly helps you move through some of those. Doesn't mean you don't make mistakes though. So there's no such thing as perfect research. People make mistakes all the time. And it's just whether you made a mistake that's an easy thing to get over or whether you make a critical flaw. All right. So that's really the difference between the trash and the treasure, as I like to tell my students, that's out there. And just because it's trash doesn't mean it doesn't get published. Trash and treasure both get published. So knowing what you're reading is also another part that's really important. But I think in terms of being successful in patient-based, dysphagia-based research, it really means solid planning up front. It means networking more than anything. So we often operate in silos. Speech pathology tends to be a referral service. So we receive patients through referral and not through necessarily being there at the time the patient walks in the door. Having to do that and learn a lot more about how we actually never see what really walks in the door as part of research. So, that is one of the lessons I learned when I was going up and growing up as a speech pathologist through the system, is that speech pathology often thinks they see a lot of the patient population that they treat. In actual fact, they see less than a third. And that's actually been proven through research. So a third of what comes in through the door gets referred to us. So our referral system, if that makes sense, the way we get our patients for research, we're only seeing the most significantly impaired end of that population. And it really gives you a false impression of what's out there. And it makes for very skewed research as well. So I think one of my best examples of my personal journey in this area was having to sit in the ER as patients walked in to evaluate early identified stroke. from the moment the patient walked in. And the amount of people that came in who were not stroke, pseudo-stroke, looked like stroke but weren't stroke, with some other diagnosis. And then the ones that came in that would never see a speech pathologist but may have had issues that could have been addressed if they were referred quicker enough. With the advent of screening procedures, I think we got more subjects or more patients sent to us that way. But even then, a lot of the screening is done by nurses. And so trying to capture that population in a research study makes it even more difficult if you never ever have exposure to them. So knowing what the inclusion exclusion criteria should be, knowing how I can network to access those patients earlier, those kind of things make it difficult to do that kind of research without really heavy planning up front.
Yeah, and also too, so you had mentioned about how we see the most severe patients, right? And so I'm thinking, well, yeah, if someone just has like a minor impairment from a stroke, then they might not reach out, or they might reach out and get a little resistance, and then it's not worth it. I'll just see how things go.
Well, they get sent home.
Yeah.
That's usually what happens, is they get sent home. A third, and a third go home, basically. And yet they could still have impairments that they struggle with in the community. Yeah. So capturing those, that makes it really hard. But those patients in the long run, you may see later on as that deficit isn't resolved.
I can imagine that there are a number of, can you guys hear a train in the background? I cannot control the train. That's a confounding variable, and I think I'm going to leave that in here because of this. So within the analogy is, within podcast editing, there are a lot of things I can control for. I can control for my kids jumping around in the room above me. I can control for, I don't know, people ringing the doorbell, maybe if I put up a sign. Can't control for trains outside doing that. And so within research, you are trying to control for different variables. You're trying to establish a relationship between, maybe it's a treatment that you're doing and an outcome. Improved tongue strength, better voice score, better E10 score, whatever it is, a number of different things that you could be looking at. And there are these confounding variables. There are things like that are other than your variable within a study that are influencing the results. I can imagine that there are a number of these within patient-centric research that must give you just a tremendous problem, especially when you're struggling to get your number of people within the study. It's hard to, how many speech pathology studies do you get that have an N over 100? Not very many, or an N over 50. I don't know. It's challenging. So how do you navigate that? I don't even know what I'm asking, but it just seems like that's got to be such a challenge to do this. And patient-centric research seems very important. So how do we navigate this?
Well, one of the things I think when we focus on patient-centric, that term alone, is that the patient gets something out of it. Okay, and a lot of times when they go into research, they don't really know if they're getting anything out of it or not. And so concepts like salience and transferability are really, really important. And a lot of treatment research, especially, isn't necessarily salient to the patient. So I do 40 Masako movements in a research treatment study versus doing none, and I have two groups. But even the Masako doesn't necessarily let me go home and eat with my family. So how is that salient to me? How do I get something from that? How am I leveraging something like the gut-brain reward system with that? That's what we're talking about here in terms of patient-centric. Keeping people into a research study, getting people into a research study, there also has to be something for the patient. They have to think, oh, yeah, that sounds interesting. I might really get something out of that. It might actually help me. Remember, that's part of the recruitment system too, is for people to think, this thing might actually help me. How about you, Mike? What do you think?
Well, I agree, but I want to go back to Tim's other example about taking healthy adults and looking at changes in lingual pressure with the effortful swallow. Now, that can be a very valuable study if the design is correct and the sample size is sufficient and the question is sufficient. You might end up with something what we would call normative data. Okay. And normative data can be valuable for comparing against patient populations, especially if they're age, gender, and have other variables controlled and matching, then you can have an idea of maybe how weak the tongue is. So let's just take a hypothetical example. I've done 2,000 healthy adults from 40 to 80, stratified by age, matched on, equalized for gender, socioeconomic, educational levels. Now I have my normative data. Now I want to take and use the effortful swallow as a treatment technique, and I'm going to measure lingual pressures. I'm going to measure tongue strength, if you would. All right. Here's the problem with that. And this goes back to what you were just saying, Giselle. Most of our patients don't care if their tongues get stronger. What they care about is, can they eat more? Can I have a steak or a blackened salmon? Can I drink a beer? Right now I'm thinking about one of our former McNeil patients. We used to have them, Giselle would always say, what at the beginning of therapy, what is your perfect meal that you want? And this one guy from England said, a pint of Guinness. And so at the end of his therapy, we took him out to dinner and we had a little food and he had a pint of Guinness. And that's what's meaningful to the patient. And it's those kind of questions that are inherent in patient-centric research. It's not to minimize the value of research with healthy adults. It's not to minimize normative data. It's to encourage people to think about, are the things that you're measuring going to have an impact on the patients that you're treating, especially if it's a treatment study? In over 44, 45 years of clinical practice, nobody cared if their hyoid bone moved further after treatment. Most of my patients didn't know they had a hyoid bone. But what they cared about was, hey, I want to have a steak, mate. That's what they really cared about. And so a lot of our research over the years was focused on that. And now what I hope Giselle will do shortly is kind of take us through the hierarchy of designs maybe that allow us to get to the important questions, because you just don't start out you're having a question and do a double-blind, placebo-controlled, randomized clinical trial. It doesn't work like that. Okay, there are many, many steps that you have to take. And 25 years ago, before I met her, I wouldn't be able to even tell you what they are now. But since I've stolen them from her, I'm going to ask her to kind of help us along the way and what this lineage of clinical research might look like. And if you want to use the McNeil approach as an example, Giselle, that's fine with me.
Look at you being nice, giving credit where credit's due. Nah.
Okay. Actually, it's really funny because recently I was at DRS and a person asked me about doing a pilot randomized control trial before they did a real one. And that was the question I was asked by a junior researcher. And I just said, that's not where you start. You'll never get funded, or you actually never get anything useful if you begin there, because that's not where we jump in to this tree of treatment evaluation. So recently I had another fight with someone about the value of mixed methodologies versus qualitative, which I get in lots of these kind of discussions because being a director of the PhD program at UT Health, that's what I do across 8 different disciplines. So it's not just speech pathology, it's across a whole range of different allied health disciplines. So if you don't know anything about this particular intervention or topic, no matter what it is, qualitative is a great way to begin. Okay, it can be small, it can be qualitative exploration, it might involve the patient, so it keeps that patient-centric focus going on, or it might involve patient and caregiver dyads. So you're going to start out somewhere like that. You're going to move to a simple, maybe cross-sectional study sometimes, if you don't know much about the prevalence of that particular issue that you're interested in. If you're looking at more interventional, more treatment-based questions. So does this thing work? Does it actually do anything? Then you're looking at a simple pre-post study, single group, case series that sort of thing, where you can measure the impact and what we call the effect of an intervention. But that's still kind of pretty crude because there's still going to be a lot of confounders you can't control, and you don't actually have a control group. The patient is their own control in some regards. Along the same line, if you can't get a lot of patients, you might want to do an A, like a withdrawal-based case study of just a few cases to see if that intervention makes an impact and effect.
Giselle, can I interrupt you real fast? Because
Sure.
I think this is a good point to make. You hear people using methods that maybe research has, I don't want to say proven, but has provided substantial evidence that they don't work or they don't do anything, or that there's not a real strong evidence base for. But you might hear somebody say, I've done this with 50 patients and it's worked. They've gotten better. And like you're talking the pre-post and the threats to that, what are some of those common threats to pre-post that maybe, because at the pre-post, basically, you don't do something, you measure where they're at, then you do some stuff, and then you measure where they're at. What else can confound that so we can come back and say, well, it might not be that as simple as you're making it seem?
Yeah, you've just said it right there. You measure. And that's one of the biggest problems we face in pre-post, especially with clinical pre-posts, because you may not use the same measurement twice. You might not do the same measurement at the post. Classic example. This is one that I've actually had first-hand experience with. We're measuring the weight of a stroke patient. And when we first measured them, they're in a wheelchair. But at the end of the study, they're standing.
Fair enough.
Now you have to go back and subtract the wheelchair weight from all of that. You see what I mean? So the measurement is part of the confounding. If you don't measure things consistently and standardly, both at the beginning and at the end, then that data is useless because there's so much confounding you can't control. It's one of the things I talk about with clinicians in my center, actually, is about trying to get what we call minimum data sets put together. So clinicians see hundreds and hundreds of patients. They're going to see them and treat them over a period of time. But getting the standardized measurement at the beginning and the end can make that data more useful for someone to go back and look at in terms of is there an effect of something we're doing here? So measurement is one of the most important confounders. Mike wants to add in here.
Well, I do. I'm not trying to step on your toes, but you use the word standardized. And the other aspect of pre-post studies, whether they're done by researchers or clinicians, that needs to be controlled is the delivery of the intervention. And one of the limitations when clinicians, and we've obviously worked with and trained many over our careers, is that if a clinician says, well, I'm going to do this, okay, because I think this is going to help this patient. Now you've drifted away from a standardized intervention approach. And with research, you really have to standardize not only your measurement, but what you're doing between the pre and the post. You can't drift because you think that something is going to work better. You can't say, well, I'm doing a study on the effortful swallow, but I saw something in the patient today, and so I'm going to add Masako maneuvers. And I can tell you in my clinical practice, which was longer than I care to remember, I would ask patients when they would come in for their first visit, what are you doing at home? And many of them, outpatient clinics, would have booklets that were maybe an inch or two thick. And they would show me all the different exercises that their clinicians had provided them. And I would say, well, how often do you do these? And they'd kind of look at me and go, I don't. It's just overwhelming. They've given me too much to do. So, keeping it standardized is not only, I think, a good thing for research, but it's a good thing for patient compliance. The simpler that we can keep an intervention, the greater the compliance is going to be. And hence, you're going to have elevated motivation as well. So those are some issues that we really want to think about when we're designing patient-centric clinical research. And as clinicians, when we're applying what we'd like to call evidence-based treatments.
Man, there's so many different
Good
directions that we can go with this. And even I think what you said about making something practical is extremely important. So, for example, last Saturday, there was, I was doing I was hosting a respiratory muscle strength training seminar with Chris Sapienza. And Chris, in the discussion, she brought up the 5 times 5 times 5 times 5 type thing, doing it 5 sets of 5 repetitions, 5 days a week for 5 weeks. And I asked the question, why not 3 days a week? Because, if we're talking about doing exercise overload on skeletal muscle, that's what a lot of general exercise physiology research has been on. You take a day off, you let the muscles rest. And she had, I thought was a strong response. The idea is we want them to remember. And so the 5 times 5 times 5 times 5 helps them to remember. And so I think that was good on that perspective too. And I've come at it a slightly different way in some of my patients. I don't know who of us is right. I'm going to probably default to her since she's the RMST expert and I'm not. But I've been I'll emphasize for patients to do it 3 times a week, because based upon what I'm hoping that I can at least generalize or hypothesize will generalize from other research on skeletal muscle, that I'm hoping compliance will be higher just because they're not having to do it 5 days a week. Now, I don't know. Maybe it depends on if they have memory issues or if they have motivation issues. Perhaps that's where it's going to come down to. But it makes a lot of sense rather than giving our patients a bajillion different things to do. And maybe in a perfect world, that's going to work better. Like they're going to get better if they work for 2 hours a day, every day, but no one's who's really going to do it. They're going to think that's beyond me. They're going to lose motivation and say, if that's what I need to become better, to improve my swallow, it's not worth it. There's no way I can do this, versus scaling it back perhaps to something that's reasonable or making it more reasonable from, a different perspective. Does that make sense? Did I butcher? What do you think?
You're talking about here is basically it's a ratio, what we call burden, motivation, and success. And we know that the greater the burden of intervention, the lower the motivation, and hence the lower the success, the outcome. You get poorer outcomes. Okay. And so what we want to do, at least I think Dr. Carnaby would agree with me in this. If not, I'm sure she's going to tell me that she disagrees with me. But I would think that in the real world, if you can develop a clinical intervention that has low motivation with high functional impact, in other words, the patient wants to do this, you're addressing a patient-centric want and need, then your success is going to be high. And, at the risk of sounding like self-promotion, when we developed the McNeil or MDTP approach, that's exactly what we focused on. We have to keep it simple. We have to keep the burden low. Patients were motivated when they came in as long as they saw functional benefit. And in this program, they're eating, they're swallowing, every day that they're in treatment, whether it's 3 days a week or 5 days a week, they're eating. And that's motivating to these people. And they often become their own therapist as the program goes forward. They know what works and what doesn't work for them. And it all starts, I believe, with that idea of low burden, high motivation, leading to good success.
It's really about what we were talking about before, which is like salience and transference. It really is. Salience, is it meaningful to me? Transference, is it something I can do in my everyday? It's not an additional burden. If you don't have those 2 characteristics to intervention, your chances of success are much, much lower. It doesn't matter whether you do 3 days a week with a therapist or 5 days a week. That's 3 hours at most. They're doing the exercise or the intervention versus 5 hours at most. They're doing the intervention. But if they leave the therapy office and what they do for the other 24 hours or 12 hours or whatever isn't meaningful, they're not embedding it into their everyday lives, then it's not meaningful and they're not getting the benefit really out of any time you're spending with it because it's not transferring. So that's what we're talking about. We have to begin to design interventions that leverage that reward system in the human being and that are motivated through self-transference. So it's something I'm going to just naturally do. I'm not doing an abnormal movement that somebody's taught me that I have to practice. Because we know as human beings, we don't follow up on practice. It's just not, adherence is really low.
That makes me think of something in my own life, and I want to see if this is what you're talking about. So I wanted to get in shape. I used to be really active when I was younger, and it is so hard for me to get out there and just be like, I'm going to run a mile. I'll do it once a week, but that's not, a whole lot. But about 3 years ago, I started playing rec soccer. I tell you what, lost some weight. My cardio is so much better, and I love to do it just because I want to go and do it. I don't have to get on my case. I get to go and meet people. I get to go and have fun, kick a ball around, and maybe score a goal or get hit in the face by the ball. I don't know. Whatever it is, it's very fun, and it's something that is very, very taxing on me physiologically, and I love it.
Mm-hmm. Well, you just nailed it in one there, Tim. That's exactly what we're talking about. And everyone's got an experience like that. If we're doing something that gives us social motivation, that gives us a reward, either because I meet people or I'm having fun or I'm driving that endorphin in system, then I'm going to repeat that action again and again and again. That is where we have to get. And what's better than eating? I mean, let's face it, eating is both social, communicative, and fun.
Mm-hmm.
And it drives a dopaminergic increase. I mean, it's going to activate the HPA axis. It's going to give you a whole bunch of stuff. And it's exercise in and of itself. So you're getting those benefits and yet getting reward. That's that gut-brain reward system I was talking about. If we don't do that with our treatments, then patients just simply will fade from them and not complete them and do them enough. And we can't be there with them their whole lives as therapists. So we have to be able to train them and motivate them to continue that action without us there.
Yeah, I think it's really easy to oversimplify this and just say, I mean, from the research perspective, you can oversimplify it, but even say if there's this perfect research study, as perfect as you can get, it studies a bajillion people in X population, and it controls for every other variable, and it shows the outcome is this much better versus the randomized double placebo controlled, control group, right? But if it's something that's very, very, very rigorous, that people aren't going to do, the practicality of it is not there, and it's likely not going to work. I mean, there's just, I think knowing human behavior, knowing just, I don't even know. Like, there's so many variables beyond what I can think of that I know are going to factor into this. But it's easy to oversimplify. Like, back to the pre-post question, you talked about the measurements. So if you're looking at weight, somebody has had a stroke and you're doing some sort of intervention. I don't know if it's probably to gain weight or muscle mass. What was the, I'm butchering that. What was the example again you're talking about? I know it was weight someone with a wheelchair and without.
Yeah, patient came in with a wheelchair, and by the time they finished their treatment period, they were no longer using a wheelchair, but, we weren't measuring it any differently.
Yeah. Well, and so the standardization of measurement before and after, but even things like the placebo effect, if you introduce a treatment and patients feel like they're getting better, so, they maybe their outcomes that they report, at least in reported outcomes, are going to be better. Clinician bias, you alluded to this earlier. You mentioned it pretty directly, that if you think something's going to work, I mean, that can influence the way you do therapy too. So if I'm going to do maybe I'm assigned to the control group and I'm like, this therapy, there's no way this is going to work because I know I'm in the control group. I'm not blinded to what I'm doing. It might affect my motivation a little bit. So there are a lot of different things going into this. I don't know. That's been a theme that's gone throughout this, is just the more you learn, the more you realize, like,
well, it's a balance, I think, between research that makes practical sense for patients, that is centric, patient-centric, and driven by patient performance, and also good design so that you eliminate some of those easy-to-control confounders. So things like the person who thinks the control isn't going to work, so doesn't put their effort into treating the patients in that group. Well, they shouldn't know they're treating the control patients. They should be blinded to that. So that's how you control that. You also measure how much they knew about what group assignment they got. So there's a design way to control some of those things. So good planning, good practice, but balancing it with interventions and studies that have a meaningful outcome for the patients beyond just a small physiological benefit. of course, we want physiological benefit for our measurement process, but we also want patient and caregiver payback. It's one of the reasons that PCORI, it's a funding agency, it's a patient-driven funding agency. It's one of the reasons why PCORI was put together, was to generate more of these patient-driven, patient benefit research studies.
So I could tell this is something that you both are very passionate about. What do you think is an example of how this has been done well in the past? And I guess I'm kind of pushing you, like, talk about McNeil a little bit, because I know that at least as I understand it, it seems like that's what you were going for with that, not only in the exercise that people are trying to do, but perhaps in the outcomes as well. Is that fair, or what do you think?
Yeah, I think so. I'm probably going to butcher this response and be corrected, but that's okay. I'm used to it. When we started McNeil, we had a question. We spent 6 months with focus groups of experienced clinicians debating, how do we do this? How do we do that? How do we keep it simple? What do we do? And from there, once we developed this framework of intervention, it wasn't McNeil then. The actual McNeil was actually the first patient who volunteered for the first study that we did. He was what we call a 2-time loser. He was a victim of a brainstem stroke and head and neck cancer. He was in the medical field and had, despite ineffective prior therapy, had basically weaned himself off his feeding tube. But he was one of these guys that was trying to eat and drink all day long, very slowly. And then in a matter of 15 sessions, he went back to eating regular food. But that's McNeil's story. I digress. The first question, as Giselle said, was, does this thing going to make a difference? Is there an effect of this study? And we were working with electrical stim at the time. And so we combined this therapy with e-stim, thinking that e-stim would give you a stronger swallow. Well, we got a nice result on about 8 patients or so. Nice case series, pre-post, 6 months follow-up, no deterioration in benefit after 6 months. But I think it was Giselle in one of our team meetings that we made a major mistake. We combined 2 treatments. So we don't know if it's our exercise program or the e-stim that gave us the bang for the buck. So we started over and we did another effect study with just the exercise program, got the same result. The next question, is it any better than other therapies that are out there? Case control study, compared it to traditional effortful swallow with EMG biofeedback. Yes, it's superior. Okay. Then physiologic studies, what's actually changing? And then finally, the end study, which was the most recent big publication. There have been others since then, but the big one was the double-blind, placebo-controlled, randomized clinical trial. That was the one that really said, hey, this worked. But what really makes it work is the patient-centric component of the McNeil approach. It's low burden. Swallowing is the exercise. The clinician does all the burden. They have to constantly be thinking in their mind what's going on. And then you learn from the patient as you go. And the patient gets benefit because they're going, hey, I'm eating. I wasn't eating before. I'm eating now. Something anyway. And then you're progressing. Then they're eating more and more and more as the program goes along, very rapidly, as I might add. And so that's kind of the history of developing this McNeil approach. Low burden, swallowing is the exercise, functional component. Patients are eating throughout the program and progressing, eating more and more and eating safely. And they are highly motivated. They don't miss sessions, whether you're doing it 3 times a week or 5 times a week. If you're doing it right, they don't miss sessions.
Makes sense. Giselle, anything you want to add? Correct.
Yeah, I mean, the one thing I love about the McNeil program is the patient becomes their own therapist. They really do. And if you're doing it right, they'll tell you when you're doing it wrong. They're all over it. And not only that, so are their caregivers, so are their spouses. So, we would treat people and then they would contact us and say, he had this tonight and he ate that tonight. And the patient would say, I was able to eat 2 plates of X, Y, and Z and didn't do that and didn't do that. And I had a great time. So they're coming back with these positive, reinforcing behaviors that drive the program. I mean, the amount of driving after the initial sessions, the amount of driving that therapist has to do is, if you're doing it right, not very much at all, because the patient's the one in the control seat, really. And that's what's kind of cool. We're training them to become their own therapists, and it motivates you as a therapist too.
So I'm going to step back and ask these questions as if I don't know anything about the McNeil program. What is it therapeutically that they're doing, or the independent variable that you're throwing in there, that is patient-centric about this?
What are they doing physiologically, or what are they doing emotionally, motivationally?
Like exercise-wise within it.
So when patients come in and they're impaired in dysphagia, they really have a restricted range, rate, and speed of muscle movement and performance. Okay. Their range is reduced. The degrees of freedom of movement that they can produce is reduced. If, for want of a better word, they're diminuted and very rigid in the way that they approach tasks. I think one of the things that McNeil does is it broadens that. Okay. So it programmatically builds the subsystems so that they can increase the variety and range of materials they're able to tolerate without any negative consequences. And so what the patient sees is they're increasing the range and reducing the effort involved in consuming different materials that they haven't had exposure to before, because simply it was too much for them, or they had very imbalanced systems that were, for want of a better word, maladaptive. Okay. And what McNeil does in 2 ways really is give them graded exposure to those things and build the subsystems, at the same time reducing fear and apprehension. And so the 2 things together give you a very strong therapist effect, but also give you a very strong patient-centeredness and a patient involvement effect. So I think that graded exposure, that follow the patient, follow when they're successful, pull back when they're not approach, really improves their motor system, just like learning to ride a bike. They're getting back on the bike all the time, but never in a position where they're at any risk, and never at a position where it's overwhelming. So they're not just taught an exercise and made to do it at home on their own. Mm-hmm. They're actually guided through the process of making those decisions and those steps, to the point where when you get to the end of the program, the patient can do it all themselves. They know when to drop back. They know when to go forward. They know how to deal with negative consequences and how to get around them.
You know, I think you added a lot more complexity to what than what I was going for. I was just thinking of they get to eat while they're doing the exercises.
Well, but there's really a lot more going on under
sure.
the skirt.
No, I just meant like that in part of it, them being able to eat while they're doing the exercises, and as an outcome, being able to eat.
But they're in control.
Yeah.
They're getting back something they felt like they didn't have before.
Mm-hmm.
Like, I want to eat, I try to eat, and it doesn't work for me, and I've lost control of this.
Yeah. So a lot of different ways that, whether it's McNeil or somebody who's doing something else, that they can make this patient-centric if we're understanding maybe the values of the patient and,
correct,
and understanding them as a person, how we can better cater whatever it is we're doing to target those things. There was a course I was working on, and I tried to take this principle from business, this impact effort matrix, where on one axis, the y-axis, you have impact, and on the x-axis, you have effort. So, going up and down, you have impact. So the higher up, better impact. Further to the right, on your horizontal one, higher effort. And the sweet spot is the low effort, high impact stuff. I mean, that's your low hanging fruit, the stuff that you go for first. And so in thinking of this from a patient perspective, it might be impact, but also thinking of impact in a way that it's something that they value, whatever their specific goal is. So I guess calibrating it with a goal that's important to them, and then thinking of a bunch of different things. And so what is it that will likely have an impact on this? And then rate the impact. But then for the effort component, I modify that to this idea of burden. So that you have the impact and then the burden. So how much of a burden is it to the patient to do this? And that's a very maybe singular way to think about it. There's probably a way to make it make a lot more sense. But to me, just thinking about the things, if this particular program, whatever it is going to be a low burden as determined by the patient, I've got to talk to the patient so they can tell me how big of a burden to them it would be or not. So if it's something that's going to be a low burden, but likely high impact, then those are the things that I want to prioritize. And then, of course, deprioritize the things that are likely to be low impact and very high burden overall, too. And we can think of a number of different things for that. But sorry, that just made me think of that.
No, I think you're on the money. Absolutely.
I was trying to read your face. I was like, do they think I'm an idiot?
No. That reminds me.
Makes
it
sense.
reminds me of the third arm of evidence-based practice is the patient's value system. Mm-hmm. And all too often, as clinicians, we're let's face it. I mean, I wouldn't want to be a young clinician today. I would be intimidated. I'm not a social media kind of guy. Anybody that's read my post understands that from the very get-go. But when I read these things that people are saying, and they're overwhelmed, they're overburdened as clinicians, and they're trying to make snap decisions. And the second arm of evidence-based practice is the clinician's experience. But if you don't have a wealth of experience to rely on, that arm doesn't apply. But the patient value, and too often we don't take the time to ask the patient, what do you want? We're going to try this in therapy. Oh, you don't like chocolate? Too bad. That kind of thing.
Here's some more applesauce.
So I mean, yeah, it's tough to be a clinician today, no doubt. And so what we try to do is put together a lot of support tools for clinicians, give them a standardized program, give them a calibration approach 3 years down the road, because to minimize drift, and all treatments have drift. We've kind of touched upon it here. And those are some things that we can do, but it's hard enough to do a good job clinically if we forget what the patient is there for and just become mechanical in our approach. We're missing the boat. And I think that's where patient-centric research can help inform patient-centric practice.
Makes sense. As we wrap up, I'd like to end with 3 questions that are kind of the same thing, but for different people. From this, and I think I'm setting you up with it, here's the easiest one. What do you think are some of the biggest takeaways for young, maybe aspiring or early researchers? Can you answer that in a minute? 30 seconds? No, I don't know.
The takeaways for young researchers. Don't try to be famous. Don't get in it to be famous. I see a lot of that. I want to be famous. I want to have my face out there all over social media. What I tell my students is, let your work speak for you. Let the clean, accurate, and meaningful approach to what you're doing scream for you. When you're becoming a new researcher, publishing is so, so important because there's so many people all around the world that won't be able to go to that conference or won't have that social media app or whatever, but they will search the literature because that's the basis of our educational practices and in particular of research. And we would always start research with where's the gap? Finding the gap means reading the literature. So publishing is really important, but let your publishing and what you publish speak for you.
Yeah. When you started, go ahead, Mike.
I'm just going to, one little story here. Early in my career, I was like all young academics, assistant professors. I wanted to publish. That's how you build your career. That's how you advance your career, get tenure, make more money, et cetera, et cetera. And one of my colleagues was the chair of radiology at the time at the institution where I worked, basically pulled me aside and said, don't be in such a hurry to be the first. Be patient and be the best. That's what people remember, the good work. And I think that's what we've really tried to do. I know that personally I've fallen short of that mark in my career. I can probably go through my CV and say, well, that's not a very good piece of work. That's not a very good piece of work, you know. But I can also go through and say that was an excellent piece of work. I hope people read that. That's an impact. And what I think both Giselle and I have kind of morphed into over the years is really focusing on research that we hope will make a difference in the lives of patients. And we base that on what patients have told us over the years. This is what I want. This is what I need out of intervention. And so I'm going to just be quiet and let you two wrap up.
That
I
makes a lot
think
of
he's
sense.
right. I think patience is something I tell people. Be patient. It will happen. And, a career is a long time. And being around and contributing little by little, all of these things help. I mean, you don't have to have a world-beating, Nobel Prize-winning piece of work. That's it. That's what I do. You don't have to. You have to be consistently contributing to the body of knowledge to assist those below you and those above you, to show them what you can do and to drive the field forward and to contribute to patients' well-being. And I think that's what we're all in it for, really. Whether you're a clinician alone or a clinician researcher or you're a researcher only, you're still there and you got there because you care about people.
Now I'm going to crank up what I perceive to be the difficulty a little bit. What about your takeaway for clinicians?
My takeaway for clinicians is you work really hard. You're under lots of pressure. Where you can make a difference is just simply measuring things that you do so you can show the powers that be that you're worth it, that you should have respect because you're able to show, I had my patient here and I took them to here. Mm-hmm. I did this with them and then I did this with them and their outcome is improved. If we can simply show that much as clinicians to our physicians, to our referral sources, to our payers, if we're able to do that, we advance ourselves, we advance our remuneration, we improve our standard of living as a therapist in the wider medical community. And it behooves us as a profession to really focus clinically, because that's where the power is for all of us. We have more clinicians than we have researchers. We always will have. It behooves us as clinicians to be able to stand up and be counted. And I really, really think that speech pathology has a lot to offer the medical fraternity, but quite often we're not recognized for it because we haven't adopted those simple tenets enough. And some of the other therapies like PT, for example, are better at doing that than we are.
Fair enough. Fair enough. Lastly, takeaways for patients. Because it's been, I mean, patients have been at the focus of all of this. A lot of the conversation's been about research. And so translating that to something that's meaningful for clinicians, I think you did great at that. Using something that is measurable to be able to, well, for one, but not for the only reason, to establish, though, that you're making a difference. And I would even take it further and say that you're making a difference for something for the patient, because then that sort of gratitude and word of mouth when they go out and they're like, look what this person did for me, that's going to continue to drive us and motivate us, and it's going to drive more people toward us. And so just so many things. But for patients, like, I don't have many patients listening to this. What's something that you think they can take away from all of this?
My first recommendation is to the patient, you're a partner in treatment. You're not a passive victim. You don't just do what you're told. You're a partner. If your clinician is setting goals that you don't agree with, speak up. That's not what I want. I really want this. I don't care if you make my tongue stronger or my hyoid bone move more, or pick any other measure that you want to pick on right now. What I really want is to be able to get this bloody hole out of my stomach patched up and have something to eat. Doesn't have to be perfect, but I want something to eat. And that's one thing. You're a partner in treatment. And with that comes responsibility. And that's up to the clinician then to have a dialogue with the patient is, I can do this, but I need you to do this, et cetera, et cetera. And so, if there are things that are happening that are not making you better and not taking you, and you don't feel that you're a true partner, it's time to speak up. That's something I've lived by for a long, long time.
Absolutely.
Hear, hear.
All right. I appreciate the conversation. Thank you both so much. I think that's probably a good place to wrap up. With that, thank you again, Dr. Michael Crary and Dr. Giselle Carnaby. Thanks again for hanging out. Doctors Crary and Carnaby bring several decades of experience, and it was a pleasure chatting with them both. No date yet, but planning a free 30-minute webinar with Dr. Crary based upon something he presented years ago at DRS. And coming soon this Saturday, May 3rd, MBS IMP Aspect C and Digest review and integration with Doctors Bonnie Martin-Harris, Katrina Steele, and Kate Hutchison. And if you're listening to this after May 3rd, it should be available soon as a recorded course. If you aren't already, sign up to the mailing list to help stay in the loop. You can sign up for it at swallowthegap.com or medslpgap.com. Your engagement is appreciated so much. Thank you for listening. Thank you for being here. And thank you for your support.